Assalamu alaikum. Good afternoon, everyone. First, thank you so much to the GIS team. First, for the kind invitation, and secondly, for putting together this elegant meeting. So, I'll talk about TAVR and bicuspid aortic valve. And because of the short time, I'll just dive through into the presentation. You know, talking about any topic or any procedure in interventional cardiology or in medicine in general, I think it's essential to answer these important four questions. And in particular to our situation here, is TAVR a safe strategy? Is it effective strategy? What is the quality of data that we base our assessment upon? And eventually, what would be the long-term outcome, i.e. durability of any intervention or any procedure? We know that the bicuspid aortic valve accounts for almost 50% of all patients requiring surgical valve replacement in young population. TAVR has become, as we all know, an accepted strategy in younger patients with AS. And certainly those patients with bicuspid aortic represent a lower cohort of risk within the low risk group patients. And therefore, the potential TAVR volume in bicuspid aortic valve would be huge. And because of that, the long-term issue of structural valve deterioration or dysfunction is becoming an important issue when we're talking about this topic. A reminder to all of you that the very first human case of TAVR was in bicuspid aortic valve. So back in 2002, Dr. Alain Crevier did bicuspid aortic valve in high-risk patients. He was rather young patient, 57, with significant comorbidity, was declined surgically because of his prohibitive risk. He underwent balloon valvuloplasty that did not work as a bridge. Then eventually he underwent antegrade intervention via transseptal approach, which was a rather complicated procedure, but the hemodynamic outcome was rather astonishing. This is the prototype of the TAVR, very first in human, crimmed in a balloon. This is the patient. One of the fascinating things also about this procedure was that actually under conscious sedation. The patient was not intubated and he did fairly well immediately after procedure. As I said, the incidence is huge of bicuspid aortic valve, one of the commonest, if not the commonest, congenital anomalies. And most of those patients, by the time actually they get the first echo, they would have moderate to severe aortic stenosis. And the prevalence of bi-aortic valve in patients undergoing TAVR was up to 50% overall. There were almost 42% of septuagenarians and almost 30% on octogenarians. So we're talking about a fairly large number of patients. When you're reading through the assessment by aortic valve, there has been actually a notion that echo alone might not be a good modality. There has been an increasing interest and recommendation in using CT in the assessment of the aortic valve morphology for a multitude of reasons. There had been several classifications based on morphology, including Sievers and Schmidtke, the bicuspid aortic valve consortium, and there has been a newly introduced TAVR-related classification, which is a proposed, probably did not receive much attention, but I think this is probably the best thing going forward when we're talking about the morphology of bicuspid aortic valve, rather than the old-fashioned classification, including the type 0, type 1, and type 2, based on the presence of absence of raphe, because their implication in the outcome is not well understood. When we're talking about this newly proposed from a big TAVR group, anatomy of bicuspid aortic valve using the CT, they basically make it simple. Either it's tricommissural or bicommissural with raphe or without raphe. The commonest type would be bicommissural raphe type, representing close to 56% of those patients. So why bicuspid aortic valve had been an issue, and probably would be fair to say a limited or strong evidence-free zone for so many years, because of several assumptions. And I'll use assumption because over the last 10 years, those assumptions actually has been debunked for the most part. It's been actually considered that asymmetric valve anatomy and calcification would pose an issue in implanting the valve. The non-circular device expansion seems to be an issue as well, and that eventually will lead to the risk of valvular leak, valve migration, annulus rupture, which is in the old days, I think, received much attention and concern, and also the occlusion of the ostia. And because of all these together and all days, it's considered that the bicuspid aortic valve in TAVI was a relative contraindication. And that's actually reflected fairly well on the old data that reflected the real life utilization of TAVR and bicuspid aortic valve. You can see that the red line at the top represent patients in their 70s undergoing surgical AVR. So bicuspid aortic valve represented close to 42%, and those in their 70s around 30%. And you can see at the bottom of the diagram the percentage of those patients with bicuspid valve who underwent TAVI. So in Europe, less than 7%, and in the US, it's only 1.6%. So very poor use in this patient. Bicuspid valve and RCTs, we have zero data because those patients had been systematically excluded for actually every single major trial in TAVI, whether the old ones or the new ones. Okay, so I'll just share with you quickly just a few studies to reflect the change of paradigm, actually, old data compared to the new, more contemporary data, which again, mostly case series or registry based. So in the old days, we had a series that included 130 patients from 14 international centers between 2005 and 2014. The use of TAVI and bicuspid valve ratio is almost 2.5%, as just the previous slide showed you that that's about the average everywhere. And in that study, most of the devices used were old devices, whether including the self or balloon expanded valves. You can see that the outcome actually comparing two devices were fairly similar. There is no difference, and actually it was very good 6-month survival close to 40 in the mid-90s. And we look at the outcome in terms of the most widely concerned complication or outcome, which is the paravalvular leak, as well as new pacemaker implantation. And when they looked at these series of patients, actually they classified them based on CT. And that's important to just have an idea that the structural valve probably has no bearing on the outcome, okay? And it did not show any significant difference, whether it's bicommitral, tricommitral, with RIFE or without, okay? The outcome is similar in terms of outcome. But this study was obviously underpowered, only 130 patients to talk about mortality of those patients. But the striking finding, which is obviously it makes sense, okay, that the low device implantation was the main risk factor or predictor of insertion of permanent pacemaker, and that was noticed on the self-expanded valves. So if it was deemed to be lower implantation, the risk of requiring pacemaker was 6% compared to only 17% if it was properly placed. And there were no clear structural features that would predict the requirement for pacemaker, which I think it's an important thing, because at the end of the day, it's actually procedure technique driven rather than pathology driven. Also, they found that the intercommitral distance actually is a predictor of development of paravalvular leak. This is a quick review. Looked at the comparing the old series and bicuspid valve, comparing them to tricuspid valve. Again, the requirement of a new pacemaker or more than mild paravalvular leak is almost similar between bicuspid and tricuspid valve. Moving on to more contemporary experience. Now this is a very actually important, I think one of the probably most important publication in the bicuspid aortic valve came from the SDS and ACC valve registry, including over 90,000 patients. After excluding several patients, they came up with a tricuspid group count for almost 80,000 patients and 2,700 bicuspid group, and they did propensity 1-to-1 matching. Okay, and they had almost 2,700 patients in each group, and this is unadjusted. Just comparing the bicuspid to the tricuspid, so the bicuspid 2,700 patients to the almost 80,000 patients, you can see the age difference. It's huge. And that's important when we're talking about bicuspid valve. And also the risk. Low risk, we have definitely younger patients and low risk patients. But looking at the patient characteristics when they matched it, when they did the propensity matching, there was no difference between the two groups. Okay. Echo showed that the annular size were actually more significant, but larger in the bicuspid aortic valve, and that's clearly basically reflected on the size of the valve used in the bicuspid valve. It tends to be larger compared to the tricuspid patient. The outcome in bicuspid, actually, they had more risk of conversion to surgery and also annular structure. But the absolute number is still very low, less than 1%. The stroke, this is the primary outcome at 30 days, was higher in bicuspid patient, but there is no mortality difference. But that increase in stroke actually disappeared at 1 year. I'll show you. Secondary endpoint also showed that there's significant tendency of requiring pacemaker before discharge. This is 1 year outcome. You can see even stroke is basically disappeared. There's no difference at 1 year in terms of all-cause mortality or stroke. What about paravalvular leak? Again, there is no difference. And you can look at this, just compare that to the older series I just showed you actually. The risk of moderate and severe paravalvular leak is extremely low with newer devices compared to the old devices. Okay. Can I just have 1 minute, if I may? Just to close up with I think the most important point that comes down actually when we talk about bicuspid aortic valve, which is durability. Now, ideally, durability of aortic valve prosthesis should basically outlast longevity of the patient, and it's very true for bicuspid aortic valve because they are very young patients. And when you look at these patients, obviously, thank you so much. It's extremely important actually to be centered, patient-centered approach. So look at this nice paragraph and look at the age of valve implantation compared to the age of the patient and life expectancy. So in those who had the valve in their 60s, we'd expect actually long valve durability to parallel their life expectancy. So younger patient, we should have actually more durable valve. And I think that's the main concern right now. Moving on, this is, now we don't have any guidelines, nothing updated actually recently, but this is a group, they actually produce a clinical practice guideline, and because of the uncertainty when it comes to durability of the valve, they basically recommended TAVR as strongly recommended in patients younger than the age of 65, and as a weak recommendation for TAVR over TAVI in the patient between the age of 65 and 75, and that's not bicuspid, it's actually in general, but obviously bicuspid valve, most of them, they would be in that age group. We don't have any big, as I said, trial. There is a single arm study that's probably going to get the result of it early next year that recorded just only bicuspid aortic valve. To sum up, basically, there is a very limited high-quality data regarding the role of TAVI and bicuspid aortic valve. Current TAVI devices seem to be safe and effective in bicuspid population. However, the risk of pacemaker insertion is still relatively high, and the long-term durability of TAVI valves remain the Achilles heel of this procedure in bicuspid aortic valve. Thank you so much.